Thank you, Raj, and I'd also like to just thank the organizers for the opportunity to do this today. We're going to be discussing the perioperative care of the keratoconus patient. A lot of this is going to tie in some recurrent themes that we've discussed already today, and we'll kind of highlight some of the other nuances. Here are my financial disclosures, including both Avedro and Oculus. So in terms of understanding keratoconus progression and criteria, first off and foremost, we need to understand that, that the current FDA approval for cross-linking is on label for progression. So there is no criteria that states what progression is. And we understand that this is a progressive disorder by nature and by definition. So documenting progression, that's a whole nother discussion and is not an easy one. Well, historically, how would we do this, or how would we get some sense of progression? First, abnormal increase in astigmatism, changes in visual acuity, or slit lamp exam findings, we all know, tends to not occur until further on in the disease state. In fact, I can't remember the last time I saw a patient had their slit lamp exam findings change under my care. One tip here is listen to your patient. That's what I found to be actually the most sensitive indicator of progression prior to the ABCD index, which we'll talk more about here shortly. Often they'll pick up and they'll give you a sense on if they feel like their vision slipped or not. Luckily, we do have advanced diagnostic equipment like we've heard about, and we're going to discuss more, including Scheimpflug tomography, anterior segment OCT, particularly high resolution has been very useful in our practice. Now we have epithelial mapping, which also gives us very nice information. We are also have in our reach the Oculus Corvus ST with the Corvus Biomechanical Index, and we're going to talk about that some. So historically, we'd always looked at shape to understand keratoconus. What's coming down the pipeline is looking at strength and biomechanics, and now Oculus has developed a combination analysis of shape and strength called the Tomographic Biomechanical Index, or the TBI. And so we've had this distinct pleasure and opportunity to validate this in the United States. And we want to also congratulate the Troutman Prize Award winner this year that was based on this paper, that now we have a peer-reviewed reference that shows the utility of this indices. The Pentacam AXL is a fabulous all-in-one device. We have had also a really wonderful experience with this. Not only do we really have a best-of-class tomographer where we get wonderful detailed information about the anterior and posterior cornea with the advanced keratoconus and progression displays that we've discussed, but we also get axial length measurements, which has been fabulous. So we have also just recently validated this against optical biometry with other devices and found there to be no difference, but this is actually all done in a single device and takes the keratometric information and the axial length information and then produces the results right on the spot for our IOL calculations. So we've talked about the Bellin ABCD keratoconus staging. I'm going to highlight just a couple other nuances that have not been discussed here in the context of perioperative evaluation of the keratoconus patient. So here's a normal eye. We can see that all four indices score 0, meaning that it looks normal. Now, here's an interesting case. This is what is thought to be maybe a real case of unilateral keratoconus. So most of us would agree that this is something that may be what we call a prospective form frus case, where there is a underlying weakening in the seemingly normal eye that has just not manifested itself yet. But the neat thing about looking at the ABCD and we can now look at progression in a relative to normal in this case, and you can see on the left panel, there's essentially no progression over time. You've got 2 time points here, and in the right panel, there's clear progression over time. So what's even more interesting about this case is that the biomechanical parameters actually tested normal in the seemingly normal eye. So maybe this is a very rare case of true unilateral keratoconus, at least at this time point. Who knows? So the Corvus ST is not FDA approved yet for biomechanical information in the context of keratoconus and cross-linking. This is a dynamic bidirectional applanation tonometer with a high-speed shine-flume camera that captures corneal deformation extremely quickly. We just recently published a combined index looking at all these advanced deformation indices, and with Oculus ran a regression analysis looking at the most sensitive and specific indices to create what is now known as the DCR index that actually can separate normals from keratoconus independent of intraocular pressure and pachymetry. So would you be surprised to hear, and I actually learned this from my good friend Cindy Roberts in the audience, who's taught me a lot, if not most of what I know about biomechanics, that IOP is probably the most important biomechanical factor in the eye. The intraocular pressure is the outward deformation holding, in some ways, holding the cornea in the correct shape. And so when you have to try to take that out of the equation if you're really going to understand true corneal strength. So the future of understanding not only progression, but now we have the ability to screen our refractive patients. So we can look at strength and shape in a combined index, which is now the TBI, and this is what we're using. Again, we're very fortunate we have the ability to validate this in our clinic right now, but I'm using this in screening all of my patients for refractive surgery. So for post-op management, we've talked about this now, but I want to just point out 2 or 3 things. We have the confidence interval bars here. So you can see the ABCD criterion over time. But if you look at the red lines, that is basically a keratoconus population. If you look at the green lines, that's a normal population. The dashed lines is an 80% confidence interval. The solid lines is a 95% confidence interval. So if we want to look at progression and you have the vertical gray hash marks, that's when an intervention occurred, such as cross-linking. So here cross-linking occurred in the gray hash mark in the middle of the treatments, and you can see now that there has actually been regression, meaning the patients have improved, they've stopped progressing. But what's interesting, if you look at the confidence intervals, you can look at a red line in a keratoconic, and if it's crossed the solid red line, there's a 95% confidence interval that that patient has truly progressed. If you're looking at a form Frisk case, let's say, or somebody you're suspicious about, if you look at the green line, and that's relative to normal, so that's where the utilities of these confidence intervals come in. So here's a Corvus looking at a cross-linking patient. You can essentially, you can sort of see the demarcation line and some of the opacity in the anterior stroma. But when we look at this, you can actually, it's really neat compared to normals. They appear to have less movement and to be more stiff. What's interesting is we want to counsel all of our patients that they're going to see a little bit worse at the first month because of reactive epithelial hyperplasia. We had to figure that out early on. We were worried that this was not working, but it just turns out that this is epithelium that is regrowing over the apex of the cornea and now has an accentuated steepness that flattens with time, usually around 3 months. Postoperative care is similar to after PRK. I do recommend that if you get a delayed healing because of the apposition of the apex, to remove the bandaged contact lens and let that last little epithelial defect heal on its own. And now with the ABCD index, we can actually follow these patients over time, where previously that could be really burdensome to try to figure out, is this patient progressing, stabilized, or regressing? But now we have an elegant way to show, with confidence intervals, stability and/or regression. Thanks very much.